Hello and welcome to HealthLine 3. I'm Terry Simmons. Today we're talking with Dr. Lise Huddleston with WK Piermont OB/GYN specialist. We're talking about inherited cancers in the field of gynecology, and we'll be taking your calls throughout the show. And as a reminder, please make sure you're in a quiet room with your TV turned way down low, maybe all the way, so you can hear us and we can hear your questions. Now the number to call is 318-219-4569, and you'll see it a little bit later and throughout the bottom of your screen during the show. Thank you so much for joining us today, Dr. Huddleston.
Thank you for having me.
Oh, it's our pleasure. And this is such an interesting topic. I think that we're going to have a lot of people really interested in hearing this. And we're going to bust some myths. We're going to put some people at ease, hopefully, with inherited. We hear that inherited cancer, those two words together.
Yeah.
But now there's testing. So let's talk about genetic testing for that.
Sure. So, this field became very popular in the early 90s. That's when we started doing genome sequencing. You heard about cloning the sheep and that kind of thing. And so we kind of turned that into a positive thing. In about 96 is when the specific hereditary cancer for breast and ovarian that I'm talking about came into play.
Okay, and then we talked about this briefly, but go ahead and remind us again, like what are the most common genetically inherited cancers?
So the thing that I specifically look for as an OB/GYN are going to be breast, ovarian, uterine or endometrial cancer, specifically for my patients.
Okay, and those are things, and not necessarily just your mother or your father. Can this also jump a generation if you had it, your grandparents?
Sure. So, part of the family history that sometimes people get a little bit confused about is what is a first or second degree relative. So first degree relative is going to be mother, father, children, and siblings. Second degree is going to be like your aunts, uncles, grandparents, that kind of thing. So that kind of also changes a little bit about what we worry about. If you have two first-degree relatives versus one second-degree relative, it's a little bit different in how that makes our ears perk up.
Okay, something to look for.
Mm-hmm.
So when we go in for the annual exam, or even just go in for whatever other reason, if we get that form that asks for family history, definitely fill it out to the best of our knowledge. Because is that the best time to talk about this kind of testing?
I really feel like that is, one of the areas where I can patients are already there and they may not realize how much information they're giving when they are. So the nurse at our office always goes through medical and surgical history, but also a family history. So, we're not just talking about diabetes and high blood pressure, we're also asking about cancers. So, and not just breast, ovarian, and the uterine, also prostate, pancreas, small bowel or GI tract, those kind of things also can be grouped together. So yeah, it's very important to be as detailed as possible. And some people don't know, and that's okay. But personal history is also a risk factor for some of these syndromes.
Okay, and that's a really good point too. Just because you're at your OB or your gynecologist for whatever reason you're there, it doesn't mean it's exclusive to those type of cancers. It could be pancreatic, like you said. It doesn't have to be just any kind of gynecological
Correct.
cancer.
Yeah, because some of these syndromes are actually looped together. And so, for example, there's a syndrome called Lynch Syndrome. That one is actually, if a patient is positive for that, the chances of them getting colon cancer is about 70%, which is very high.
Yeah.
And so you don't think about colon cancer and uterine cancer, but in that syndrome, those two actually are an increased risk and go together. So it's important to be as detailed as you can, about a family member's specific kind of colon cancer, what age they were diagnosed. That's also a red flag that we look for. So in patients who were diagnosed younger, typically for breast cancers less than 50, or in colon cancers less than 50, those definitely are things that make us a little more concerned. So if your mother was diagnosed with breast cancer at 35 versus someone who was diagnosed at 70, it may be nothing, or it could be that the reason she was diagnosed so young is because she has a specific genetic mutation.
Oh, gosh, that's interesting. Is there Is there a more common age range that women typically get diagnosed with breast cancer?
Yeah, so breast cancer, you're going to see that more, 50s and 60s and 70s. So that's why in any patient who comes to me and says, yeah, my mom, had a double mastectomy at 42, that's kind of one of those things where I'm like, did she have genetic testing? If not, does she have any sisters that have had breast cancer? And so, age is also an important component to that family history.
Very interesting, because it's a good time. Also, another myth we're going to bust right here if you hadn't thought about it. I know that in my family, and knowing a lot of people too who have been through this, if also a reminder to keep getting tested. Like my grandmother was diagnosed with breast cancer in her 80s.
Yeah.
And she had already stopped even going to the doctor very often.
Sure.
She thought, in my 80s, I thought I was past all that and done with that. So it's a good thing to remind you, don't be worried, but as long as you're alive and you're still going, then go ahead and keep getting tested, go to the doctor, keep getting those checkups, because it can happen. No one, I did not know that the age range was that later in life.
So different. Yeah. And so, even we do kind of have a shared decision making once patients reach 70 or 75 about continued imaging. The longer we live, the more likely that something unfortunately bad will happen. So, cancer tends to be more common in our older patients. But that's not to say exactly what you said. Continue to come and see us. Continue, don't ignore symptoms like breast pain or, changes in the contour of your breast. Those kind of things are also things to think about.
Yeah, and it's also a great positive way to reframe that too, as
Sure.
you've been well in doing that with our conversation even this morning, that it's kind of a good badge of honor, as long as we are living longer and we're healthier in our later years. So yeah, I'm still going to the doctor even though I'm 70 years old or 75, because I want to stay continued health. I'm not done.
Yes.
I still want to stay, I'm healthy. I'm
Yeah,
still
and
I,
a person who specifically comes to mind, my husband's grandmother is in her 90s and has a better social life than I do. So, it is important. And those are some of my favorite patients who come in and they've been seeing me for several years, and, they're 70 and I'm like, you still have parts that don't go away that we still need to check on. So it is still very important in your older age to come.
That's a very nice way to look at it.
Yeah.
I'm really glad we're talking about that today.
Yeah.
So are there, what kinds of cancers are tested for?
Yeah, so I kind of wanted to hammer two different types of genetic mutations. So the first one is going to be, and probably patients, there are celebrities and things like Angelina Jolie, that have come out for BRCA1 and 2, so BRCA1 and 2. That one specifically for our patients, we're looking at endometrial and ovarian cancers. So, we figured out over time that ultrasound is not really the best way to look at ovarian cancer. Ovarian cancer is pretty sneaky. By the time we find it, typically patients are in later stages. Luckily, we have a fabulous gynecologic oncologist in town who takes care of people from all over the country. But we want to try to catch them before we're at that point. And so, in those patients who kind of spark my interest and their family history seems very strong, I do recommend genetic testing for these people. And so what that's going to tell us is if you have a BRCA1 or 2 mutation, the chances of getting breast cancer in your lifetime are anywhere from 45 to 70%, depending on which mutation you have, as well as ovarian, which can be anywhere from 15 to 40-something% to get ovarian cancer. So if those patients come back positive and they haven't had children yet, we kind of talk about, okay, are we on the track of going ahead and having babies? Because ultimately the recommendation for those patients is going to be bilateral mastectomy by 40 or 45, and then having your ovaries removed. And so, that's a very difficult conversation to have with patients. It's one of those things where if I have a patient that tests positive for that, a lot of times, or every time, I end up sending the patient, after our conversation initially that this has come back positive, I'll send them to a breast surgeon to kind of talk about options and different things like that, because there are a lot of options in terms of reconstruction and that stuff. And then also a genetic counselor. So, whenever you are talking about having this genetic mutation, well, obviously we're talking about hereditary things, so you can pass those on to future generations. So genetic counselors are a great resource for patients to use. And the wonderful thing that has come about from COVID is kind of that uptick of telemedicine. And, we have one genetic counselor who's also fabulous in town, but there are several in New Orleans and all around the country. So you can, have telehealth and telemedicine visits with those people. You can also have telemedicine visits with those people before you even have the genetic testing. So they may go through and tell you, these are the implications. And I do have some patients that have a strong family history and have just decided, I don't want to do the testing, but I'm going to be, very diligent about getting my mammograms every 6 months and my breast MRIs and alternating those. So that is another thing, doing this testing isn't without implication. It is going to change your life. And so it's not something that should be taken lightly.
That was really I'm glad you went to that, because that was one of my questions, even thinking about this last night.
Yeah.
If you do, there are some people who just really love their life, they're healthy, they're having a great time, they just don't want to know because they don't really want it in the back of their head.
Absolutely.
They know their mother had that or it happened, it's in the family, but they may just not want to know.
Yeah.
And do you find that? Do you have patients that do that?
I have patients like that. And, if I was faced with a similar situation, I've had this conversation with colleagues before, I don't know what I would do. I do know that it's important to understand, what's available, and that's why kind of before you do the testing, speaking to me or a genetic counselor or even your family members, is so important, because it is a tough decision. I fully support patients who decide not to do the testing. I understand that. It changes your life, and I 100% get that. I may be a little more like call them on the phone and they haven't seen me in 12 months kind of thing, to make sure that they get in and see me more often. And some people, you'd be surprised, after 6 to 12 months have maybe changed their mind.
Right.
None of this is anything that a patient should be forced into doing. It's just kind of giving them the information and letting them make a decision.
And luckily it isn't like do it now, do it. You have time to go and talk it out and go and find out all the information. So,
Yes.
all right, we have an Esther on the line. Hi Esther, thank you for calling. What's your question?
My question is, when you have a vasectomy, and after you have your vasectomy, and you're told to go and have the other breast checked out and everything, well, my doctor told me she had to take the nipple off the other breast to make a nipple for the one that they put the implant in. I was okay with that, but now I have itching around the nipple a lot. So is there any problem? I've had it checked, but they say I have no cancer in that and everything was okay. But I keep getting this off and on itching. And sometimes it feels a little sore, but nothing is there. Should I keep being worried about that?
So I think the most important thing is to make sure that you're not noticing any skin changes around the area. It sounds like you've been really good about following up. You definitely could potentially may want to speak with the breast surgeon again. I'm not sure who did the surgery for you, but it's always best to go back to the physician who operated on you. So I would encourage you, if it's still bothering you, to not let that go. If it's 3 to 6 months down the road and you're still experiencing something, to go ahead and call that doctor's office. Now, you can certainly have skin changes, especially if you have, some tightness of that skin while it's healing. You can have itching. So just kind of be mindful of it, but definitely, bring it to someone's attention if it's not better in over 3 to 6 month period.
Yes, ma'am. I will do just that, because every so often it really itch. Even with the bra, I take the bra off and it itch. And I alcohol it, and it after a while it stopped, and then later on it'll start back itching. But the skin is not tightened. My breasts look really nice. It is not swollen or anything like that. I just worry about it.
Yeah, you definitely want to use more like ointments and creams. So alcohol will dry that skin out. So you want to use something more like a an ointment or a cream that will keep it moisturized. So that's important too.
Okay.
Even like a cocoa butter, I tell patients to do like vitamin E capsules for scarring and things like that. So you could try that as well.
Okay. Okay. I'll do that. I will do that. And I thank you very much, doctor. I really do thank you so much.
Yes, ma'am. Have a great day.
Yes, ma'am. You too. Bye-bye.
Thank you so much for calling, Esther. And she brought up another good point too. We're just really, some of us think, well, that's just what we're going to live with. That's, I had this is just going to happen. It's just the way it is. But keep going to your doctor. We're not supposed to be uncomfortable. If you have anything that's uncomfortable, keep going to your doctor who actually did the surgery or that you've been talking to see if there's anything you can do.
Yeah, definitely. You know, especially for post-op complications. I'm not sure how long ago she had her surgery, but certainly, you know, it is important. And physicians are there to help. So we want to make our patients feel better. And if you're having some sort of concern, even if you get repeat imaging and we don't see anything, that's at least peace of mind instead of you worrying about it. So.
Yeah, it's complete peace of mind because doctors are everyone. It's just keep coming back. It's okay. You're not going to be like, look, I've talked to you enough about this.
That's right.
And you want it. Plus, the more information that a doctor gets, the more they'll be able to help you be comfortable.
Absolutely.
So, so what kind of family history do you actually look at? How extensive of a family history and what leads to other things besides the obvious? What is a family history that might lead to genetic testing?
So, you know, I'm thinking of a patient in mind right now. So you, especially on one side, so maybe, you know, a paternal grandmother had breast at 67 and a maternal grandmother had breast at 50. Really, we're looking at both sides, like one side of the family. So maternal aunts and a maternal grandmother. You know, I have a patient who tested positive. She has 5 sisters and 4 of the 5 are positive. So several sisters being positive, several aunts on the same side being positive. Again, the male breast cancer is something that really, you know, that is not common at all. So that's definitely one that when a patient tells me that, you know, I definitely have this conversation about the genetic testing.
Definitely. And has it been like if your father had breast cancer and you're the daughter, is it the same as if your mother had it?
So it's not a sex chromosome thing. It has to do with like the autosomal, not to get too nerdy, but
no, I love it. Go ahead.
A father could pass it to a daughter, yes.
Okay. That's so interesting. I love it. No, you just get as nerdy as you want. This is this is what I love about HealthLine 3.
The neat thing about all of this coming about is there have been several tools that have, or screening tools that have come about for this. So, you know, the Academy of College of Obstetrics and Gynecology says, you know, don't screen every single patient with this tool. Every single patient that comes in doesn't necessarily need to take a quiz about, you know, their family history. Do the basic family history, you know, that the nurse takes and go from there. And then, you know, there are several tools out there that will actually kind of tell you if you are a candidate, because everybody wants to know, is my insurance going to cover this? And so a lot of times patients who take this quiz, a lot of companies will work with you. And so even if you have the blood drawn, the specific company that we use, you know, will contact the patient and say, you're going to get a bill. You know, these are the things that we can do to kind of work through it. Whether it's the physician needs to maybe do some different documentation, or our company will work with you. You know, so those screening tools are also helpful that a lot of primary care physicians have at their disposal.
Yeah, right there. You know, if anything, I hear this. We've come so far, and I think, do you find patients or someone who comes to you with, you've had the patient, the mother or something, and the daughter may just come to you, I want the genetic testing. Yeah. Is it a relief either way? Like sometimes even if they find out that they are a candidate, there's a sense of relief there because they can, now they're aware. Yes. And they can do something.
Yeah, I think there's kind of 2 schools of thought. There's definitely the patient that's like, I want to live my life to the fullest, and I'm the kind of person that I am. If I know I'm positive, this will loom over me. And then I have, you know, the 20-something-year-old that says, I watched my grandmother and mother go through all this, and I would rather be prepared. And if it means that I get breast imaging every 6 months, or, you know, that I talk about family planning a little sooner, you know, I'm okay with that because I'm going to take it on, you know, head on.
And do you even find that within families? There may be, a couple of sisters and one will be like, nope, I'm good. And the other one's, I want to know now.
Yes.
Test me immediately.
The patient I was talking about with the 4 sisters, that there's a pendulum of who is kind of like, I want to know, and some that drag their feet, and for obvious reasons. I mean, I totally get that.
And the good part about this too, like we said a minute ago, you don't have to get tested immediately and do something about it. You have time to really ground yourself and be ready for whatever you find out.
Yeah, this test is a blood draw. It's a venipuncture, so it is something that, and we have the kits in our office, so it's something that can be done at any point in time once you're ready for that.
That's really great. And what if someone says, take it, you keep the results, don't tell me right away, I'll come to you when I ever have that? If
I have a positive result, I tend to do that. I tend to do that face-to-face, but I will say in the day and age of everything's at your fingertips, a lot of these companies will give the patients a login and an email so they know before I have a chance to talk to them. So I always bring patients in for a face-to-face conversation because it can be overwhelming.
Yeah.
It can be a lot to talk about. So yeah, that is definitely something that I do face to face.
And we don't ever know what's really going through someone's mind.
Sure.
Even if you're okay, and then you get the blood drawn, and then it's done, and then there's all kinds of things that can come up, which is nice that you have counselors, genetic counselors, people they can talk to too. And it's just
yes,
nice.
a lot of the companies have adapted. They have their own genetic counselors and have for some time, but now I feel like it's become even easier for patients really to utilize that tool. With telehealth and all of that, so that's a great tool that the company that we use specifically, they are really great about patient education.
Right, and the more you know,
yes,
this is better.
Yes.
So tell us, speaking of that, now what questions should someone ask the doctor?
So I think, the biggest question I get is, do I have to have surgery, and what does this mean for, imaging and things like that. So specifically for, if we're talking about the Lynch Syndrome, which is the colorectal or colon cancer with the endometrial cancer, you're going to be getting colonoscopies a lot more often. You're going to be really good friends with your gastroenterologist or your colorectal surgeon. If you are positive for something that increases your risk for breast cancer, typically you're going to start imaging 10 years before your youngest relative was diagnosed, and that will include a mammogram and a breast MRI alternating every 6 months.
Okay.
Where general OBGYNs come into the picture is going to be if a patient's reached 40, 35 or 40 depending on their mutation, and they're BRCA1 or 2 positive, then we'll recommend removing your ovaries and your tubes. Or if they have Lynch syndrome, we talk about hysterectomy. So that's kind of where the generalists come into it. Really, we just kind of start the ball rolling if somebody comes in with just an unsuspecting history.
Okay, and it's even if, like we talked about, after childbearing age, and you have kids, you're good. Even if you've decided you're never going to, do you find that a lot of women are just their identity is still attached to having breasts or having a uterus or having hysterectomy? It's just really an emotional thing. Even if they know their health is at risk, it's a very difficult thing to let go of.
It is. And so kind of where general OBGYNs come into the picture again is kind of what about after? What do I do now? And so, the beautiful thing about Shreveport is we do have so many specialists here, plastic surgeons and breast surgeons here who can kind of help give you your options as far as, full reconstruction and all of that versus, the other side. So once we take out your ovaries, patients are like, oh my gosh, I'm 40 and I'm menopausal and I'm hot all the time and I'm cranky, and you're limited kind of in what you can do with that. So that's a lot of kind of what generalists deal with is kind of the after, which is why it's so important to kind of establish that relationship with your patient, because if they're coming to see you every 6 months because they're miserable, I want to do everything I can to make her comfortable. I can't change her genetics, but I can certainly make her feel better.
Yeah.
And so, I want people to know that your generalist OBGYN can definitely help with some of the aftermath of that.
Okay. So let's talk about menopause then,
Yeah.
and the onset of that once your ovaries are taken out, say at 40, since we're talking around the 40-year-old
Yeah.
range. And so is there anything that you can look at and you know this patient or you know their history, that because some people never even, if they do go through menopause, they don't even know it. They've been healthy, like, I don't know, I don't have that.
Those are the lucky ones.
Yes, yeah. But then some have it very drastically and call
Yes.
it their own summer.
Yes.
But if you do have a 40-year-old, is there any way that you can know that this patient might have early onset menopause without their ovaries, or is there any way to tell?
Yeah, so we call it surgical menopause. I mean, if they've had their ovaries removed, they may have a few months of circulating what we call endogenous estrogen, or estrogen circulating around. Estrogen is stored in fat tissue. And so they may have that for a few months. But once you have your ovaries removed, you've done it. It's gone. So menopause is coming. And some people do it, like you said, it's a lot more graceful. And some people tend to have pretty significant changes, whether it's vasomotor symptoms, memory changes. One big thing that we talk about is actually osteoporosis or osteopenia. So a patient, your ovaries, the reason we live longer than men is our ovaries, because for heart and bone health, ovaries are cardioprotective, and they protect our bones. So that's what I tell my patients. I'm like, this is why you're going to outlast your husband, is because of your ovaries. But once those are removed, then we have to talk about, okay, talking to your primary care provider, making sure that they know, hey, my ovaries were removed at 42. He may want to start you on a statin, or monitor your blood pressure more often, or your cholesterol, those kind of things that put you at risk for heart disease. And then also bone densities. So those bone density studies, the DEXA scans, we start those earlier in patients who've had their ovaries removed in their 40s or gone through menopause in their 40s. Because what we don't want to happen is you to be 55 and already have osteoporosis, because then we're doing an uphill battle. So if you fall and you have a fracture of your hip or your back at 55, that's young. And so that is definitely something that we have to be aware of too.
And that's very interesting about how powerful those ovaries are.
Yes, they are. They're powerful.
We're not living longer just because we're tougher and smarter. It means because we've got ovaries.
No, there's a real scientific reason. Yeah.
That's really is interesting. It's amazing how both bodies work, male and female, but when you really look at all of that. And so let's remind people too, what is it about the ovaries? Is it the hormones that they manufacture that when they go away? So what all?
Yeah, so the biggest thing, again, without getting too nerdy, the biggest thing is going to be the type of estrogen, the type of androgens that they secrete. And so those tend to, like I said, be protective for heart and then bone as well. And so once those are gone, you kind of lose that protection, and then we're left with, just the prevention and your calcium and vitamin D, and making sure that your primary care provider is aware that you don't have those anymore.
Okay, that's fascinating.
Yep.
So what is something else? We're going to have to close, which I hate to. I could talk to you all day about this. It's been really great. So what's one thing you'd like to leave us with about this genetic testing in gynecology?
Yeah, I think the most important thing is I want patients to understand that an OBGYN is our field is fascinating, and we don't just deliver babies. We're here with patients through, the end of life, menopause, all of that, and things have changed, and I think that our field is just a wonderful opportunity for women to kind of express exactly what's going on and really take charge of their health care and being healthy for all their future grandkids.
Love that.
Yeah.
And to really communicate with you and realize that
we're a friend, we're an ear, and we have a lot to offer patients.
And then even though we're talking about gynecological cancers or problems or issues, we can ask you about anything.
Absolutely.
And you can refer us if you've done everything you can, you want to refer us to someone else, but we can ask you about all kinds of things that's going on.
Absolutely. Mental health, anxiety, depression, those things is really something that we like to focus on as well, not just postpartum, but kind of, again, menopausal changes can cause a lot of things to change, and so we talk a lot about that too.
And sometimes if you just don't know, there's just
Yeah.
something off and wrong you don't know.
Yeah.
And we go to you and ask, and you can just put us at ease and let us know what to do about that.
Yes,
All
definitely.
right. Would you like to give your phone number or website or anything, how people can reach you?
Sure. So our phone number is 318-212-3890, and our website, I think I remember it, is PieramontOBGYN.com. And we're also on social media, so you can follow us there as well.
Okay, and thank you so much for empowering me, knowing that those ovaries, we can always just, so that ladies, you can just tell your husband, listen, I got ovaries, I'm going to outlive you. So
That's right.
Behave yourself.
That's right.
Well,
That's
Dr.
right.
Huddleston, this has been fascinating. Thank you so much for enlightening us and busting some myths and putting us at ease. I think this has been really informative, and we really appreciate you being here.
Yeah, Terry, it's been fun. So
I'm so
I hope
glad.
to come back some.
We
soon.
would love to have you come back.
Yeah.
We really would. We could talk about any topic and reminding us about OBGYN and everything you have to offer. So thank you again.
Yes, ma'am. Everybody come and see us.
All right, everyone come see us. And thank you so much for joining us on HealthLine 3. Have a great afternoon, and we'll see you next time on HealthLine 3.